And start.
Okay, share the slides, please, if you can share. Otherwise, I will share. Okay, slide share is coming. So, welcome all of you to this 183rd session of Thursday Musings. The host has muted everyone. The panelists can unmute themselves. The questions are invited in the chat box. They will be taken up to the presenter. Session will be recorded and put on the YouTube channel. So, a very basic topic, spin out of the previous topic, EEG for postgraduates. In fact, we all should be very interested in this because today we'll learn the basics of EEG. Next slide, please. Share the next slide. Yes, I'm handing over the session to the chairman of the program, Professor Dr. Tufan Pati, sir. Sir, over to you.
Thank you, Dr. Rim. And formally, I shall mention the names of our vibrant moderators. Treasurer of IPS, Dr. Lim Siddiqui, and Secretary of IPS Office here, Dr. Amrit Patujoshi. Over to the next slide. Our chairperson, Dr. Bisal Chavra, is an old friend on this platform and is a graduate and postgraduate from Kasturba Medical College, Manipur, with 21 years of post-training. He is currently the HOD and Senior Consultant, Fortis Hospital, Salimabad. He is Life Fellow of Indian Psychiatric Society, Indian Association of Biological Psychiatry, Indian Association of Social Psychiatry, and Indian Association of Private Psychiatry. He is the recipient of Ravi Pandey Memorial Award, WP Fellowship in Child Psychiatry in 2008, and HN Federation Fellowship in 2012. He has 15 published articles in index journals and 2 chapters in psychiatry textbooks. Besides, also on Delhi Psychiatric Journal editorial board. He is currently the immediate past president of Delhi Psychiatric Society. He was president from 22 to 23, vice president 2009 to 21, general secretary 2017 to 18, and treasurer 2010 to 2016 of the same organization. He is currently the co-chairman of the IPS membership subcommittee, and his academic areas of interest are phenomenology, mood disorders, anxiety disorders, addiction disorders, psychopharmacology, and neurobiology. Welcome, Dr. Bislucha. Next slide, please. Dr. Sobit, who is also an old friend on this platform. Welcome, Dr. Sobit. Present designation and affiliation. Professor, Department of Psychiatry, Sri Guru Ram Rai University. Alumnus CIP, Chairperson, Neuromodulation Committee of IPS. Convener, Social Media Subcommittee of SAR, Co-Chair, IPS Suicide Helpline. Past Secretary of Psychiatry, State Branch, Uttarakhand. Past Convener, Social Media Cell IPS. Executive Council Member, IAPP, UK. Member, Editorial Board of IJPM, reviewer in various national and international journals. His areas of interest: bipolar disorder, brain stimulation, research and publications. He has 65 plus publications in national and international journals, including 14 book chapters. Awards: authored paper which won the BPSS and Taraned Award, SIPCON 2021. Co-authored papers which won Pune University Murugappan and Mapati Awards. At and SIPs. Welcome, Dr. Sobit.
Thank you, sir.
I hand over the meeting to Dr. Sobit and Dr. Chavra.
I said Dr. Nishant is the co-chair.
Dr. Nishant Goyalo, I forgot, he is also co-chair, Professor of Psychiatry, in charge Center for Child and Adolescent Psychiatry, FMRI Center and Center for Cognitive Neurosciences. He is in charge of academics. He is in Central Institute of Psychiatry, Ranchi, India, Program Coordinator of CIP Digital Academy, General Secretary and Founder Member, Neuromodulation Society. Past Editor, Eastern Journal of Psychiatry. Associate Editor, Journal of Child and Adolescent Mental Health. Areas of interest and specialization: child and adolescent psychiatry, non-invasive brain stimulation, public mental health. Number of publications 100 plus, awards and fellowships 30 plus, fellow India Alliance, welcome DBT. And welcome Dr. Nishan. With this, I hand over the meeting to all the esteemed chairpersons. Someone will introduce our speaker, Dr. Deepak Goyal, and the other will introduce the topic. With this, I hand over the meeting to the chairpersons and co-chair.
Sir, can I introduce the speaker, sir? Nishant boss, then you can introduce a topic.
Yes, please.
So it's my pleasure to introduce. I think sir is the most renowned neurophysician in Uttarakhand. So and it happened that we worked together. I had this fortunate time to work with him for I think 2 or 3 years, and I was taken aback by the vast clinical applicable knowledge and the practical approach of Dr. Deepak Goyal sir. Sir is currently the professor in and heading the Department of Neurology in HIMS in Dehradun. Sir is actually an ex-alumni of SGPGI, and he was the ex-director of Max Hospital, Dehradun. Sir also was the president of UP UK Neuroscience Society. And if you go through Sir's publications, Sir has vivid publications in epilepsy, in epidemiology of epilepsy. Sir is a very renowned faculty in this area with an allied interest in neuroepidemiology, stroke regeneration, neurorehabilitation, and chronic pain, where we have Sir has a lot of publications and research work with a recent interest in neuromodulation. With this brief introduction, and I think in Uttarakhand, Sir doesn't need any introduction as such. So I would like to welcome Dr. Deepak Goyal, sir. Thank you.
Thank you, Chairperson Dr. Shobit and Dr. Nishant. And it is my great pleasure to see you all together on this front. And I am very pleased to be the part of this meeting. And the organizer team, my seniors, my colleagues, and dear students, this will be a great opportunity to discuss some practical tips and some practical aspect of EEG and a relevant practical approach. Actually, EEG, am I audible to all?
Yes, sir. Yes, sir. You can put the slides in full screen now.
Okay, sir. So, EEG is a technique and device which needs to be discussed much together. Actually, we have a course of EEG training program through Indian Academy of Neurology. Dr. Chaturbhuj Rathore is running that course throughout the India, and it is a 3 month course of EEG techniques and application and assessment. So EEG is such a topic that it cannot be covered in 40 minute 1 hour time. So today my aim is to discuss some technical aspect as well as the practical aspect in brief for the postgraduate and the persons who are doing EEG in daily routine. So हम लोगों में एक कहावत है ना, जैसे कि जो है नाम वाला वही बदनाम है। तो EEG इज सच ए टेक्निक जिसका नाम भी बहुत है और ये बदनाम भी बहुत है, बिकॉज ऑफ इट्स uses, misuses, overuses and underuses. So these are all terms related with EEG. तो आज हम लोगों ने जो अपनी टॉक है उसको हमने बहुत की पॉइंट में डिवाइड किया है। बेसिक एडवांटेज एंड डिसएडवांटेज, व्हाट इज द एक्सपेक्टेड यील्ड इन ईजी। एक्चुअली ईजी सब लोग करते हैं टू फाइंड आउट समथिंग और रूल आउट समथिंग। तो अल्टीमेटली यील्ड है क्या इसका? ग्रेडिंग ऑफ एबनॉर्मलिटी हम लोग कैसे करते हैं? रोल ऑफ ईजी इन नॉन एपिलेप्टिक कंडीशंस लाइक बॉर्डर जोन डिसऑर्डर की हम लोगों को ऑर्गेनिक डिसऑर्डर वर्सेस फंक्शनल डिसऑर्डर में कैसे डिफरेंशिएट करना है? Is there any EEG patterns which can decide about the etiological diagnosis? That we will discuss. And is there any predictive value of EEG? And that EEG means routine OPD scalp EEG. There is nothing like, epilepsy monitoring EEG, intracranial EEG, quantitative EEG. That are the different form of the EEG which will not be discussed today. The basic scalp EEG, 1 hour EEG, what we can do and what we can assess. So if we see the advantage and disadvantages of EEG, the main advantage, wide and easy availability of the techniques. It is available everywhere in the towns. You can get anywhere without any difficulty. Cost friendly. A patient do not think in getting this EEG. This is a technique which is a real-time monitoring of the brain function, which is wonderful function, and the valuable differentiation between organic versus functional disorder. It is very, very much useful. Disadvantage, as I told you, it needs a technical training for doing it and interpreting it. And that technical training is a long time, 3 months to 6 months at least. Most common misutilized technique, or it is having very poor yield. If you get 100 EEG, then yield will be very less. So that why sometimes the clinician are very much discouraged in doing or getting the EEG. But we will see the other aspect also today. There is very high inter-reader variation in reporting. That is the main key factor, because of the variation in training, because of the variation in the expertise of various EEG interpretation. There is high rate of inter-reader variation even in the master class persons who are doing daily reporting and doing only electrophysiology. Still there is a inter-reader variation, and frequent under and over reporting of the EEG is a negative aspect associated with EEG. This is one paper where the very highly expert people in United States evaluated 10-second sample of 12 selected EEGs, and they have found there was a considerable variability in EEG interpretation. So I told you this is a technique where inter-reader variation is very high. So we will leave this negative aspect, but we will see what are the positive aspects in this technique and how can we best utilize this technique in our clinical practice and day-to-day practice. So first we will talk about the yield. Yield. Actually, there was a paper in year 2006 by Dr. Sullivan, and he has challenged the concept: should really in psychiatry practice EEG should be done or not, because yield was less than 7%. That was the question raised in his paper, whether really EEG is contributory in psychiatry practice or not. So this is a discouraging statement initially. Later on, as soon as we discuss the other aspect of EEG, this 7% was a little negative presentation of this paper, because there are many positive aspects we will see in later half of the presentation. If we see overall positivity of EEG, there was a study, this same study, they have evaluated around 1500 referrals of EEG from electrophysiology lab, from neurology, from psychiatry, from general medicine, from pediatric and other department. And the total yield of abnormal EEG was 27%. That means 73% were normal EEG reported from that lab. In another study, among the subject with single unprovoked seizure, cumulative first EEG abnormality is 39% only. That means around more than 60% of the patient will have normal EEG even in single unprovoked seizure. As soon as you increase the frequency of EEG, the number of the abnormality can increase up to 72% after third or fourth EEG. So these are the two basic things. The yield is low. The inter-reader variation is there, and interpretation variability is there. So now we will some basic aspect we will see EEG. EEG में हम लोगों को दो इंपॉर्टेंट चीजों पे बार बार कमेंट करना पड़ता है. मैं जितने भी पोर्चुगीज में अगर इन्वॉल्व हो गए हो इस मीटिंग में, तो मैं उनको बताऊंगा, अगर आपको इनिशियल 6 महीना प्रैक्टिस करना है EEG पे, तो दो ही चीजें देखो, बैकग्राउंड क्या है. और
Deepak sir, there is a request because there is a pan India audience. Some are not good in Hindi,
maybe.
so use
Okay.
English.
No problem. So the two important pillars of EEG interpretations are the background and the transients. So my request to postgraduate is that please just do repeated reading of EEG regarding the background and the transients. Transients are episodic waves coming in the running EEG with a constant background, and that transients and background can be divided further. The background can be normal and abnormal. Normal background is depending on age and the stage of the person and drug taken by the person. So three important things. Age means the infant will have a different background, the early childhood will have different background, and the adult background will be different. So the background should be seen by the age of the patient and the phases, stages of the patient, like sleep, wake, REM, non-REM, and the background then can be abnormal, and abnormality can be generalized or focal. So this is the basic program, and this is the biggest challenge when we see the background normal or abnormal, generalized or focal. Then further expertise required for identification of transient. And the transient can be classified into three categories: artifacts, which are external source of the noise; the physiological, which are coming from the body, but they are not related with the brain abnormality; and the pathological, like epileptic discharges. So this is the basic program which we have to understand. So background, as I told you, is changing with age, physiological state of person like wake or sleep, and the drugs taken by the patient. So we have to take detailed drug history before getting EEG in the lab. The posterior 8 Hz alpha, which is the normal PDR, known as PDR, posterior dominant rhythm, develop by the age of 3 years, and then it get matured and it remains same throughout the life. The sleep EEG in OPD setting, OPD lab setting, is possible only up to the stage 1 and stage 2. Stage 3 and stage 4 sleep are not seen in routine daily OPD EEG. These are seen only in the video EEG lab. Slowness of the background can be graded according to the severity, which I will tell you now. And anterior beta, central mu rhythm, temporal theta are also part of the normal background rhythm that we will discuss soon. So the normal background can be, divided into 5 grading of abnormality. If dominant rhythm is alpha, it is grade 1 without any theta delta, so it is a normal. Grade 1, grade 2, if there is a theta, or delta, which is detectable with alpha, then it is grade 2 abnormality. Grade 3 abnormality will be dominant theta and delta without detectable alpha. Alpha is not there. Then it is grade 3. Grade 4, low voltage delta rhythmic activity, which is polymorphic or multimorphic. Then it is 4A. If it is monomorphic delta, it is more severe, and it is 4B. 4C stage is periodic discharges, low voltage, and background rhythm is not seen. And fifth is isoelectric, which is seen in the brain dead patient. So these are the 5 grading of abnormality. So now we will change the screen with a EEG. So I will show you just a normal EEG, and I will show you the basic things in a short time, which are very important for the postgraduate to understand. This is a live EEG. I think it is visible to all. Please tell. It is visible to all.
Yes, sir.
Okay. So you see the parameters seen in the EEG. This is the sensitivity. Normal sensitivity written here is 7.5 microvolt per millimeter. Means this is the voltage of the EEG wave. If we increase the sensitivity, then there is a reduction in the size of the waves. So we have to make EEG readable till the time the waves are not mixing with each other. So we should change the automatic recording will be 7.5 microvolt per minute. So for reading purpose, we can change up to the 20, 30, 50 according to the clarity of the waves where they are not meeting with each other. The second column is showing the paper speed. This is a 10-second epoch in one EEG, which can be condensed to see the periodicity to the 15 millimeter per second. So this is now looking a compressed EEG for looking the periodicity. It can be further compressed to 7.5. Then it will be like a PSG, polysomnographic EEG. So EEG can be compressed according to the paper speed. Normal speed is 30 millimeter per second. Other two are the low frequency filter, that is 1 hertz, and high frequency filter is 70 hertz. The usefulness of these two filters is very important. The 1 hertz filter will remove the waves below 1 hertz, and 70 hertz filter means that higher frequency more than 70 will be filtered out. So we will see the frequency between these two filters. And many technicians, what they do, just to make a very clear EEG, they change the filter setting to 35. I will show you in the further where the muscle artifact will be there. Just to for clearance purpose, they change the filter setting, which is a wrong practice. The last is the notch filter, which is important for removing the electrical artifact from the EEG. These are the montages. We are showing the montages. This is bipolar. Those person who are using this is, they must be knowing that there are two type of the montages, unipolar and bipolar. The bipolar montages are the banana run montages, where the both electrodes are active and channel is showing the potential difference of the two electrode. And these are red are right and blue are left because they are odd in number. The initial four channels, they are temporal channel, and later four channel, they are parasagittal channel. So temporal, right parasagittal, left temporal, left parasagittal, and these are central channel. So this is the basic nomenclature in EEG, and these are frontopolar, anterior frontal, or anterior temporal. The two names given to this channel: mid temporal, posterior temporal, then again frontopolar, frontal, central, and parietal. So these are the name given to this channel, and O is occipital. So what I will want to show you, that please recognize this dominant alpha in the background. You can see dominant background is O1 channel on the left side and O2 channel in the right side. That this is a dominant. All postgraduate make a very good practice of looking this alpha. Just make a visual impression in your mind that alpha look like this. It is a sinusoidal alpha, and if we run this EEG, you will see that the frontal will be beta, and there will be theta and mu rhythm in the central, and then there will be alpha. So this is a normal EEG of a young person, which is looking very great and very simple, very easy to understand that we are going through a normal EEG. So make habit to just do all the frequency reading in this EEG. Here there is a transient coming up. This transient is not disturbing any background. When there is no disturbance in the background, then these are not labeled as a pathological transient. This is just a normal increase in the potential gain because of the some negativity charge over the brain, but it will come and go without disturbing the background. So this is a normal transient. So this EEG is a normal EEG, and you should keep in this mind that normal EEG, when you see 10, 20, 50 EEG, then you will recognize the focal slowing and the generalized slowing in the EEG. So I think this is all about I want to tell you in this short section of lecture. Then I will go to my presentation again. So now I will start few cases to understand what is the utility of this EEG in background understanding and the transient understanding. So I will now present one case: 54-year male presented with recent onset forgetfulness, confusion, confabulations, urinary incontinence, and judgment error in last few weeks. The background illness none. Personal history: alcohol uses almost daily. No seizure, no jaundice, no GI bleeding, no fever in recent past. Routine testing were normal. Higher mental function testing, poor attention and orientation. Neurological examination, gait abnormality. So, with this background, when we could not see any metabolic cause or any infective cause for this disorientation, we got his EEG. And you can see the EEG and CT scan together. These are the even name. So this is the right uh, frontal right frontal lead, which is showing very large delta, monomorphic delta slowing, and this is the left F7 T3. So this is the slowing on the left. You can very well make out in the background that from this part, the slowing is very obvious here and slowing is very obvious here. So we can correlate structurally that with small SDH on the right side corresponding to this slowing and very large SDH on the left side is corresponding to this setting, showing a bilateral SDH. Patient must have fallen sometime, which he has forgotten, and he presented with these changes in cognitive feature. Another case, 62-year male with chronic alcohol uses, presented with fluctuation in behavior and agitation from past 1 week. Then he started frequent insomnia and aggressive behavior during night. His medical parameters were normal, but liver function was slightly deranged with high enzymes and low albumin, suggestive of some chronic liver disease. We got his EEG and we found a beautiful triphasic wave pattern with slow background, suggestive of metabolic encephalopathy. So these two examples I have given where the normal background is disturbed, no alpha background. One patient has focal slowing, showing a structural brain lesion, and another person showing generalized slowing, metabolic factor. So the message by these two cases is that if we are getting generalized slowing of the EEG, it is moreover metabolic and drug factor. If we are getting focal changes in the background, it is suggestive of structural lesion in the brain. Headache is a very common condition in practice of neuroscience, and we see a lot of cases of headache and we describe clinical we know that most of the cases are primary headache patient, either migraine or chronic tension headache and other type of the headache, and sometimes we feel challenges in diagnosis, counseling the patient or patient family, especially in childhood, about the headache, etiology of the headache, and whether it is an organic headache, it is a secondary headache, or it is a primary headache. So sometimes EEG is being used in headache practice. So, what is the yield in headache? In one study in 2020, 259 patients out of 259 patients, 31, that is only 12% patients show abnormal EEG in headache cases. So, yield was 12%. Of these 31 patients, abnormal EEG, 17 showed epilepsy from discharge. This is really important. That the patient out of these 31, 17 had epilepsy from discharges and 11 showed rhythmic change of slowing. The frequency of EEG abnormality was significantly high in patients with migraine with aura. So if we see all studies together, epileptic discharge can be seen in 10 to 12% of the patient in headache patient. Focal and generalized slowing can be 8 to 9%. Migraine headache is associated with higher changes of abnormality as compared to other type of the headache. There are poor correlation with EEG abnormality with radiology. So it does not mean that if we are getting abnormal EEG, so radiology should also have correlate in images. The EEG is an underutilized tool in the patient of chronic headache, as claimed by this author in 1994. Epileptic headache is a very rare entity. Sometimes we use this term, epileptic headache, that it is a manifestation of ictal phenomena. Headache is ictal phenomena. But few temporal lobe epilepsy has shown that headache is a ictal phenomena, which is very rare. This is very interesting meta-analysis in year 2023. This meta-analysis showed that coexistence of epilepsy and headache, migraine headache. This is a real paper which is showing that around 80% patient has increase in lifetime incidence of migraine in patient with epilepsy, in person with epilepsy. Person living with epilepsy has more chances of lifetime incidence of migraine headache. And reverse is also true, that there is 80% higher chances of seizure in person of migraine headache. So this meta-analysis concluded very recently, which suggests a bidirectional relationship of headache and epilepsy. So I think EEG is a very good tool in refractory epilepsy cases. So I think if anybody is using EEG in a patient refractory to drug, chronic headache, not responding to drug, and we are not finding any imaging abnormality, then we should go for EEG, which is a good technique. Now, the second condition, we will use yield in PNES patient. PNES patient, we can get EEG just to see that it is a normal EEG. That is one aspect, or there are other aspects which we will discuss. In a study of PNES patient retrospective view, all EEG reported that they have seen two groups of the patient: pure PNES, that is non-epileptic seizure, psychogenic non-epileptic seizure only, and psychogenic non-epileptic seizure with true epileptic seizure. So they have taken two groups. So in group with PNES and true epilepsy patient, there were 92%, 92.9% of the patient had abnormal EEG. While in patient with PNES only, 53.8 had one or more abnormal EEG, and EEG changes were non-specific in 42.3%. So changes were there, but they were not indicating specific pathology. In the study, 18% of the patient and 10% of the control also had abnormal EEG as reported by the author. So what I mean to say that even in PNES, non-specific slowness or change in the background rhythm or some transient can be reported which are non-specific. But there are reported EEG abnormality in PNES. This is more interesting that about 78.4% of the PNES patient had normal interictal EEG and 21.6% had abnormal ictal EEG. And out of these, 10.8% patient had epileptiform discharges. So what is the message? That even in the era of video EEG, so much technique and clinical assessment, we can miss true seizure among the patient of the PNES. And this relationship of coexistence of PNES with epilepsy is well known. I will demonstrate through this case what happened with us. This is a video came from the patient from his mobile, her husband mobile, that the patient is having these kind of the symptom. In the kitchen, she was cooking food, and suddenly she become, unresponsive, staring look, not doing the usual activity, standing in the kitchen and just roaming around. This phenomena was occurring very frequently in 3 to 4 times per month. So this video came to us. Then we called the patient because routine EEG we have done in our lab, which was normal. So we have asked for the long-term video EEG monitoring, and we have done the EEG of this patient. And she was now started some activity, and you can see, I am stopping here. You see the focal epileptic discharge in this patient. There are beautiful focal discharges on the F7 reversal, showing that there is a mid-temporal, the anterior temporal spikes. So we have found out that left-sided temporal lobe focal epileptic discharges suggestive of some left temporal epilepsy. So we planned for another, because rule is that we have to record at least 2 or 3 EEG. So another EEG recorded, and you see the same activity. Sorry. Next slide. Yes. So we have got MRI because there was left temporal spike, and we have seen a beautiful temporal sclerosis on the left side. And we have done the another episode recording, and you see the movement of the perioral movement. It is difficult because there is small video, but perioral movement she started. The same focal epileptic discharges she is having. And in the later part of the 2 EEG, we have recorded 2 PNES episode along with the two seizure episode. So this patient was having 2 seizures as well as false seizure. That was the mystery in this patient. So we have diagnosed this patient as having temporal lobe epilepsy along with PNES. This paper has shown that simultaneous occurrence of non-epileptic seizure with epileptic seizure during the single period of inpatient video electrography. So this is known that many patients of true seizures will have PNES, and many patients with PNES will have true seizure. So this is worthwhile to do very detailed EEG analysis of these patients. Now we will see whether EEG is useful in etiological diagnosis rather than the physiological diagnosis. So epileptiform discharges, very specific, contribute to change in the diagnosis and treatment. We know once we got generalized epileptic discharges, primary generalized epilepsy, there is no other test to catch the diagnosis. So very specific in catching the generalized epilepsy. Limbic encephalitis, this is very important, that delta brush is one important disease which is catch hold by EEG, and a specific diagnostic that it is a patient of limbic encephalitis. Metabolic encephalopathy, we have seen triphasic wave, classical etiological diagnosis by EEG. Gross asymmetry, suggestive of structural lesion, and rapid onset dementia in CJD, very specific diagnosis. So now we will see another case. The case 13-year school-going girl, which is brought to outpatient psychiatric facility in a tertiary care department by the family, and she has acute behavior disturbance about 2 months ago, consisted with fearfulness, suspiciousness, and some stalking her and planning to kill her. She was also seeing some of the faces that she had difficulty to differentiate from dreams. She lost focus in her studies. She felt uncomfortable while socializing. She had low-grade fever proceeding to these features, but not get settled easily. During these 2 months, patient family initiated sought spiritual treatment first, followed by a faith healer, and then consulted general physician who prescribed antipsychotic in form of risperidone 2 mg, but she could not tolerate it due to tremors and other side effects, and which appear within 24 hours, and they have stopped this treatment. Then again, they have given some kind of the antipsychotic in form of olanzapine, but this was not well tolerated and patient has stopped, and then the reference was sent to the neurology department. And what we have seen, the typical delta brush. This is a delta brush, delta slowing with a top beta, that is delta brush. And in the MRI, there was a temporal hyperintensity suggestive of NMDA encephalitis. So this was a typical case of NMDA encephalitis, which presented with the predominantly psychiatric manifestation. Another case, 62-year male, old woman, 62-year-old woman, previously healthy, presented with 3 weeks of progressive short-term memory loss, dyscalculia, dysgraphia, appetite loss, frequent episodic left arm dystonic posturing, and eyebrow elevation. On examination, she had finger agnosia, dysarthria, a graphesthesia, and stereognosis bilaterally with myoclonus. She had rapid deterioration condition and admitted to tertiary care center. The patient showed typical 1 Hz spike pattern in the EEG, suggestive of CJD, and MRI shows typical changes of CJD. So these are the two examples where etiological diagnosis can be confirmed with EEG. Now the last part of my presentation is role of prediction in the disease progression or disease outcome. This is a paper where the predictive value of EEG is seen in dementia patients. The patients were included on the basis of diagnosis of dementia due to Alzheimer's disease positive with amyloid and tau cerebro CSF tau marker and the available EEG recording. The patient was categorized into two groups, normal EEG group and abnormal EEG group. Out of 1 in 4.5 patients of Alzheimer's dementia having visually normal EEG, this group showed a better overall cognitive performance as compared to the abnormal group. This was one outcome where memory was the most prominent affected domain. So the worst outcome was seen in patient where EEG was abnormal. The normal group showed less global and parietal but similar temporal atrophy. Follow-up data showed that slower deterioration in all tested cognitive domain in normal EEG group, which means you can predict the progression of disease on the basis of EEG in dementia cases. In cases of psychosis, there was one study. There was a widespread consensus that EEG is not useful for the detection of clinically relevant abnormality in patients with psychosis. At their initial assessment, 61 patients with first episode of psychosis had an EEG classified according to the following modified Mayo clinical system of grading from grade 1 to 5 in background abnormality. At the end of 1 year, 19 out of 21, that is 90% of the patient with normal EEG had remission of their positive symptom as compared to 18 out of 28, that is 64% of patient which has essentially normal EEG, and only in 7% where patient is having dysrhythmia. So तीन कैटेगरी थी इसमें, मतलब there were three category: normal EEG, essentially normal EEG with some doubtful non-specific finding were there, and dysrhythmia. So the worst outcome was seen in patient where the dysrhythmia was there. Negative symptoms were reduced in 61% of the patient with normal EEG as compared to 35.7% patient with essentially normal EEG, essentially normal, and none in the patient 8% of dysrhythmia. So the author has shown that if you categorize these patients into the normal, marginally normal, and abnormal EEG, you can predict the outcome of these patients. And the last was the prediction in patient with schizophrenia. They have graded the EEG into three abnormality: grade 1, the focal abnormality; segmental abnormality, more diffuse; and a diffuse delta activity, DDA. They have given name as DDA, diffuse grade 3 DDA. So grade 1, grade 2, and grade 3. So what author has seen? 43 chronic schizophrenic patients with diffuse delta activity in their resting awake EEG were compared with 23 chronic schizophrenic with normal EEG. In diffuse delta activity group, they were divided into three, as I told you. The temporal persistence of DDA, brief and intermittent DDA, and prolonged DDA. So this organized type of the schizophrenia was more frequently associated with DDA, and residual type of the schizophrenia was more frequent with normal EEG. The doses of neuroleptic as well as those with phenothiazines and butyrophenones were higher in patient of diffuse delta activity group, and 1 year follow-up shows that in diffuse delta group, reducing the dose of neuroleptic resulted in tendency for DDD to disappear, which suggests that a drug was having role in appearance of this slow activity, and reducing doses of adjacent carbamazepine causes DDA to disappear further. So there is a role of anti-epileptic, mood stabilizer, as well as the phenothiazine group of the medicine. So my take-home messages are: EEG yield may be low, but it is a useful tool in practice to differentiate between organic and functional disorder. Still, coexistence of functional neurological disorder with organic brain dysfunction is well known. Therefore, searching through EEG or video EEG can be useful. Few EEG patterns are indication of specific etiology. Few EEG studies suggest that we can have a better prediction of the disease outcome. Overall, EEG is a useful tool in clinical practice, and future development in quantification, spectral analysis will create more powerful evidence for brain disorganization. Thank you very much.
Thank you so much, sir. Very, very simple, in very simple language you have explained it. Over to chairpersons for their opening remarks.
I think I'll start.
Yes,
Yes.
sir. Yes, sir.
Yeah.
Yes, please.
So, thank you, Dr. Goyal, for providing a primer on EEG, particularly, which is very, very important for the postgraduates who are working in the field of psychiatry. As you have rightly said, EEG is something which is often over, misused, particularly in the psychiatric fraternity, and your lucid presentation will definitely pave path for many youngsters who wish to learn EEG in the right perspective, in the right manner. And I really appreciate the way you summed up your presentation with some research studies where EEG findings were seen systematically in various psychiatric disorders. Thank you so much for your lucid presentation. And with this, I hand it over to my co-chairperson, Dr. Shobhit Garg. Over to you, Shobhit.
Sir, as usual, very lucid and wonderful presentation, sir. I think it's a revisit kind of a thing. So a very key thing which you actually told us is the wave should not overlap. So we can actually adjust the intensity to the amplitude. So that the clarity is achieved even at 7.5, 15, and 20, which is actually we are taught that 7.5. So that is a very good thing. And then normal transients will not disturb the background. It's two very good things. A very interesting case vignette, like even in patients having clear cut anterior temporal spikes, there is a chance of subsequent event which can be a PNES. So I know sir is very clinically, sir is an acumen of detecting patients clinically also, whether the patient is having epilepsy, seizure, or an PNES component, and more or less sir is actually correct. So a pleasure sir listening to you. Thank you, sir.
Should I
Thank
speak?
you.
Acha, please.
Sir, there are a few questions in the chat box.
Ji, sir.
One is regarding photic stimulation. The full question is not understood, but photic stimulation, how to use and what is the benefit, where to use?
जी सर. Actually, मैं इसी में बोलना चाह रहा था कि मैं डॉक्टर शोभी, I was just planning because the postgraduate should have a basic understanding of reading full EEG. So in any time, if the organizer and the team member decide that I can take an exclusive class of postgraduate on technical aspect of EEG, that will be wonderful, because they should know the basics. Without knowing the basics, the mistakes are very common in EEG. So that is my one submission to the society, and I will please to teach these, because I am already doing this to all my DM postgraduate. They are also very weak in understanding this technical aspect. So now the related to the question of the photic stimulation, actually we use to do activation procedures very commonly in our EEG lab in day-to-day clinical practice in OPD. And the two most common activation procedures are hyperventilation and photic stimulation. Actually, the hyperventilation is known to precipitate many type of the primary generalized epilepsies, especially the absence epilepsy. So this is a dictum that 3-minute hyperventilation should be done. And similarly, the photic stimulation is done to find out the photosensitive epilepsy, which is a part of the primary generalized epilepsy in patient of the JME, that a special segment of juvenile myoclonic epilepsy is having the photosensitive or photoresponsive, photoconvulsive response. So these two activation procedures are very useful in our OPD practice.
Okay. Thank you, sir. Sir, another question by Dr. S. Full name is not there. How do we identify the disturbance of background by the transients?
Yes, very good question. As I was showing this, the normal EEG of a young person, and I have shown one, the large potential came, and everybody will see with doubt that is epileptic event or some discharges. So disturbance in background means that you are looking continuously over one EEG reading, and you see that there is a 7 to 8 hertz, 9 hertz alpha is going on, and suddenly the background changes to 7 hertz, 6 hertz. That is a disturbance in the background. And that background disturbance, along with the transient, is an abnormal transient.
Okay. Vishal, do you would take any question or Shobhit? Sir, one of the questions I have, sir, what is the minimum configuration of an EEG machine one should have for a basic lab? and so which is sensitive enough because there are a lot of configurations, the machines, like minimum number of montages, which
This
is
is
practical also.
Dr. Shobit. This is Dr. Shobit. This is very important to know for everybody. That's
Yes.
why I was talking, because that IAN forum I was telling you, Nishant is the name of that forum, which we talk 3 months together, continuous lectures for EEG, and in that 2 hour lecture is only on the technical aspect of the EEG, where we have discussed what should be the amplifier, sample size, what is the sampling rate of the EEG, what should be the exact parameter you have to see while you are buying a EEG machine, and what are the parameters you should see check before buying the. So I can take a brief talk on this, the how to select a best machine, और उसमें सैम्पलिंग रेट क्या होना चाहिए, उसका रिजेक्शन मोड कितना होना चाहिए, उसका एम्पलीफाइड सेटिंग क्या होना चाहिए, वो सब इस तरह की चीजें पता होनी चाहिए. आई थिंक दैट विल नीड ए सेपरेट टॉक एंड विद टेक्निकल एस्पेक्ट.
So there is a question also that is there any online certificate courses for EEG provided by Indian Academy of Neurology, and can
हाँ
psychiatrists join that, sir?
हाँ जी बिल्कुल कर सकते हैं, निशान वाले सब ज्वाइन कर सकते हैं, देयर इज नो रेस्ट्रिक्शन ऑफ ज्वाइन.
Okay, sir.
This is, there is a different fees for technician, different for resident and different for faculty. 3 उसमें उन्होंने अलग अलग वो बनाए हैं, ग्रुप बनाए हैं, और टेक्नीशियन के लिए तो 1,000 रुपया फीस रखा, बहुत कम फीस रखा उन्होंने, तो वो बहुत अच्छे फोरम है, एनीबडी कैन.
Sir, how do you go and join that? Can you?
वो हम लोग ऐसा करें, we will provide that link to some of you and you can spread it.
Right,
Okay,
sir.
maybe Dr. Shobit, you can take the
Yes.
link from sir and.
लास्ट ईयर वो मई में हुआ था शुरू, इस साल भी हम लोग उम्मीद कर रहे हैं कि मई में शुरू होगा वो.
Right, sir. Right.
जी.
So so there are a lot of questions in the group. Yeah, one was how to do EEG when child is uncooperative. One question is that. There's
So
another
this is
one.
very, very simple. There is a lot of pediatric patient coming to the lab for EEG, and ranging from the day one neonate and up to the 5 year, you will face the challenge. After 5 years, we have some control over the child. So what we are doing in neonate, we have no problem because there is no reactivity, no movement. So we are doing very normally without any sedation in neonates. Neonatal EEG is easy to do. Once the child start moving and crying loudly, so there is artifact production in the EEG. So we are using the chloral hydrate because we have to use such a drug which is not harming the electrical waves of the EEG. So we are not using midazolam, diazepam, clonazepam, lorazepam to sedate these children. So we just simply give the chloral hydrate.
Okay, sir. Thank you.
So what is the name in which it is available? Brand name?
It is brand name is
Triclofos.
yes.
Sir, what is
Sir,
the dosages?
dosing.
Sir, as per the
Dosing and expected side effects. Dr. Shweta wants to know.
This is very simple because the formula is 1 mg per kg body weight. 1 ml.
And what are the expected side effects?
This is really very safe. Nothing, no respiratory depression, nothing like that.
So 1 ml per kg body weight, right, sir?
Yeah.
how
there's-
to
Yeah,
yes,
go
sir.
ahead. Go ahead, Shobit.
How to report EEG, sir? Under which heading, sir?
Yeah, this is another, very technical question and very important question because I think, do you give EEG reading in your final MD examination to candidate?
Yes, sir.
Yes, sir.
Yeah. So
Yes, sir.
that's same is in the DM examination. So the parameter we have formatted our reporting pad in the heading. So first is the patient detail, patient's drug history, patient clinical history, patient stage while coming to the lab, and the other aspect like any temperature, any clinical condition. We will take the detail. Then the first column contains the EEG is done in awake, sleep, or under sedation. Then second is the background rhythm, predominant background posterior and predominant background anterior. So both student has to write down the anterior rhythm dominant कौन सी है और posterior rhythm कौन सी है. Then we come to any transient scene, grading of the transient, any artifact scene, any focal periodicity discharges, attenuation of the voltages, background abnormalities, and then ultimately the grading of the abnormality and final conclusion.
Okay, sir. Sir, people have asked any basic test to learn about EEG. Any basic book or text you will recommend?
Nee, sir, books.
The best book nowadays is by Dr. Radhakrishnan and Chaturbhuj Rathore. The best EEG book, wonderful. ये जो मैं कोर्स बता रहा हूँ ना निशाम वाला, ये सारा उसी बुक पे बेस्ड है. This is the only, I can tell you, this is the only book I will refer. Number one, Dr. Radhakrishnan, Dr. Radhakrishnan, Dr. Chaturbhuj Rathore.
Right, sir. Thank you, sir. Sir,
There are
somebody asked
two
on
questions.
delirium tremens पे एक question है. आप पूछो.
Yes, sir. Yes. So DT, sir, what any EEG findings? What findings will get in DT? Or the parallel question is, कि any patient admitted in confusional state, acute confusional state, then what to give to patient to sedate subsequently for cooperation for EEG?
Okay. Means hyperactive delirium.
Yes, sir.
Hyperactive में तो कोई प्रॉब्लम आती नहीं है.
Yes, sir.
Okay. So
Hyperactive.
again, hyperactive delirium. So what we have seen that in patient of delirium tremens, only useful finding which we have seen is etiological confirmation of underlying pathology is triphasic wave. That is really important. Otherwise, non-specific grade 2 to grade 3 slowing is seen very commonly, which will not tell you the exact diagnosis. Exact diagnosis, once we see in triphasic wave, it is wonderful that we know that metabolic derangement is there, and we will find out that metabolic derangement. So always in delirium patient, we are very much keen to see triphasic wave. I will tell you a key finding in triphasic wave. Triphasic wave is first surface negative sharp, a spike, then a long upward deflection, long downward deflection, and a wide upward deflection. So first down, then up, then down. ये 3 phases होती है उसमें. So first down is sharp, and later down is wide, and in between there is an upward deflection of long, wide and sharp. ये combination है triphasic wave का. पहला तो ये rule है. Second rule is that there is an anterior to posterior lag of the triphasic wave. Once you see the triphasic wave in frontal area, it will be earlier. You see the triphasic wave in occipital, it will be later. So there is a lag. Once you see these two things, the sharp component, long component, and wide component, and the frontal is earlier and temporal and occipital is later, it is 100% metabolic acceptable. So this is the specific finding, non-specific slowing is there. And the second question, other question, sedation of a patient with delirium is done usually by the antipsychotic drugs.
Okay, sir.
And in such cases, they have to weigh the.
Initially in Sanjay Gandhi PGI, paraldehyde was given to these patients. Our PGI protocol was paraldehyde intramuscular was a safe and non-disturbing in these patients. But nowadays paraldehyde with glass syringe is not available, so this is now obsolete.
And sir, if I may add a word here, word of caution, we have to give additional drug in delirium that has to be taken care of. Whether we are gaining enough by doing EEG versus adding the burden of another
Yes.
medication.
Yes, yes, Definitely. This is actually delirium patients are very difficult to get MRI as well. So sometimes what we see, if we can get EEG and focal abnormality, nowadays lot of autoimmune encephalitis patient coming in delirium. So the MRI is sometimes very difficult to get in these patients, and EEG will give a very useful information that we are dealing with a generalized pathology or a focal pathology. That is really wonderful.
So what was the pattern in autoimmune encephalitis?
This is this delta brush is wonderful finding, and nowadays we are getting very beautiful delta brush in our lab. After we were not recognized it, we were just passing out it is as a slow EG. Now as soon as we trained, we saw, then we confirm. Now in NMD encephalitis, recently a young girl of 12 years from Muzaffarnagar district came with untreated psychosis and abnormal behavior, intermittent seizure, and beautiful delta brush, and she was found NMDA positive in CSF.
Sir, if I may ask, what does a delta brush look like? I don't know.
It is a delta. 4 hertz is delta.
Yes, sir.
Dome like delta.
Yes,
And
sir.
the top of the dome, there is a brush of beta.
Oh,
Brush of beta.
oh.
So this is known as delta brush.
It's like fingers coming out the top of a curve.
Yeah, top of dome पे जो top पे fingers आती है ना वो
Right.
brush है.
Okay. Right, sir. Thank you.
Okay, from chat box, in absence seizure, what will be the specific pattern?
Absence to classical देखिए, absence are 2 types and divided on the basis of the age of onset. Below 7-year age onset, it is known as childhood absence, and above 7, it is known as juvenile absence. And classical is the 3 hertz spike and dome pattern, which is seen beautifully precipitated after hyperventilation. And after looking at EEG, the shorter phases of spike and dome seen in the childhood absence, and longer duration of the epileptic discharge is seen in the juvenile absence. Longer the duration of spikes, then it is a juvenile absence. Behave like juvenile absence.
There's a question by Rupali. Sir, can you once again please show the differentiation between 3 hertz spike and 1 hertz waves?
It is really important. It is really easier to see because in a 10-second epoch of EEG, 10-second epoch of EEG single page, there are 10 segments of straight line. It means that between 2 straight line there is 1 second. 1 second of EEG duration. And during that 1 second, if you see 3 spikes, it is 3 spike, 3 hertz. If you see 1 spike, it is 1 spike, 1 hertz. So between the 2 lines, you have to see how many spikes you are seeing.
Right, so very simple. Thank you, sir. That makes sense. I hope Dr. Rupali got her answer. Any other questions, Dr. Ali?
One
Dr.
question
Ramrit.
here, how to differentiate between delta brush and sawtooth waves?
Sawtooth wave तो इक्टल हैं. Sawtooth wave इक्टल होती है टेम्पोरल में. वो तो आप जब लाइव रिकॉर्डिंग करते हैं ना, हम लोग लैब में वीडियो ईजी करते हैं, तो वीडियो ईजी इक्टल डिस्चार्ज इज टिपिकल सॉटूथ. थीटा हर्ट्ज होती है 5 to 6 थीटा वेव सॉटूथ, typical localizing value that this is the site of the origin of epileptic focus.
Right.
Okay, so sir, I think we have covered all the questions. So since you are a neurologist, so as a psychiatrist, हमको EEG, where all do we get the benefit of EEG? As a psychiatrist, what is your summary then? Where should
My summary, sir, yes, this is the the basic home take home message today meeting. I want to tell you this is a very useful tool, very useful tool, and it is going to be a more useful in coming years. Once spectral analysis will be there, you will find enormous development in the field of EEG. In psychiatry, it is going to be change the practice of psychiatry with spectral analysis. And there are now data available that the alpha asymmetry and a ratio of theta and delta, they are very well correlated. The band analysis correlated with the disease outcome and disease response to the treatment. So this is one of the important tools which every psychiatrist to understand in depth. And my submission is that EEG should be known like you are driving a car. It should not be dependent on the other person. कि साहब EEG कर दो, हमें बता दो क्या है इसमें. That will be the worst part of EEG. EEG should be known by heart, and you should know how to handle the EEG, how to do EEG, how to interpret the EEG, and you should devote at least 3 months time to understand the deep aspect. That is why the which I told you, the over reporting, under reporting, and this misutilization. We have to stop this because this is a very important tool to use in clinical practice.
Very wise
Thank you so
words,
much.
sir.
We have covered all the questions. If anyone wants to ask any question, otherwise we go to chairpersons.
So I think we again had a wonderful session, full 1 hour of the deliberation and discussion on various aspects of clinical EEG, particularly important for psychiatry residents. And I'm sure in the crowd, there must be many youngsters who have got greatly benefited by Sir's deliberation. I would like to thank, on behalf of all the chairperson, I would like to thank Dr. Deepak Goyal as well as the organizers for giving us this opportunity. Thank you very much. And I move on to Dr. Shobit if he has to say anything. Dr. Shobit.
Dr. Nishant, any words on spectral analysis if you want to add in our lab, what is going on?
See,
Currently.
Sir has very rightly pointed that at times in psychiatry, finding ictal, interictal abnormalities may not be the best way of looking into the utility of EEG. So a lot of softwares are available these days where we do a lot of source density analysis, spectral analysis, and there are various algorithms where we do a lot of things like low resolution tomographic analysis, which is known as LORETA, which basically provide you some idea about a particular band of electrical activity which is arising from a particular part of the brain. It may be correlated with the clinical features of severe mental illnesses like schizophrenia or mood disorders or obsessive compulsive disorder. And I must tell Dr. Deepak that sir, apart from doing clinical EEG in psychiatry particularly, we do a lot of quantitative EEGs as well as evoked event-related potentials where we check various behavioral paradigms in various psychiatric disorders, and that is where the role of quantitative EEG plays very important role in the life of a mental health professional, particularly psychiatrist. So this is some words from my side which we have been doing, and I'm sure all of us, particularly from CIP, are very well aware of. Thank you once again, Aleem and Amrit.
डॉक्टर निशांत, इसके लिए ना मुझे आपकी हेल्प चाहिए कि आप जस्ट आई नीड योर सपोर्ट एंड हेल्प टू make me aware of the spectral analysis, band analysis. Please help me.
Sir. Anytime, sir. Anytime.
Wonderful.
Shobit.
Things that I've already shared, but I think I'll request the organizers that we can have more sessions from Sir's side. One basic for the PGs and then more case-based scenarios. Sir, I have a whole lot of case-based scenarios regarding those borderline cases of functional and PNES and other movement disorders also. So I think that will benefit all of us from clinical perspective. So a wonderful and enriching session. Thank you, sir. Thank you.
Thank you. Tufan sir has had to leave.
Yeah, Tufan sir is not there. So first of all, from the core of my heart, I would like to thank Dr. Deepak. So we have a couple of neurologists who have come to our musings and have enriched us like anything. And we have Dr. Nishant, and who has taught us EEG. All the things which we have been discussing, he has been after us, and he has done a bad job out of me and Aleem. We have never been able to learn EEG. Shobit is another man who has learned the tricks of the trade and is doing a great job of all the EEG and all. So thank you so much. We had wonderful attendance. We more than we wanted, even though it was a repeat. People told, "Why are you repeating?" I told, if you go to a good shop, have the best food, you can always go and have it another time. So these things are very, very important. Like sir told, I think he summed it up very well, that you need to drive your own car. You can't have a driver. You need to do the EEG and interpret it yourself. So that's the take-home message today. That, and if it requires one session every 3 months, we are always okay, because new PGs are always joining. People want to brush up their knowledge. Every time we have a new speaker, something new is learned, and if we learn 2 lines, I think that's a evening well spent. That's what I always believe in. And I think that was a wonderful session. The chairpersons were absolutely wonderful. Vishal is good. Halim is great. And I just came to end it up. Thank you so much.
You are
Thank
you are the best. Good night.
Good night. I hope to meet you again, all of you. We had wonderful attendance. In spite of a repeat topic, we had wonderful attendance.
250
Bye-bye.
plus we crossed.
Thank you.
Yeah.
Deepak sir, we could not see your face.
It is the fault of the camera, not mine.
So then we have to call you again.
Okay, thank you.
We'll call him again.
Camera
We'll be
ठीक हो
case-based scenario. Thank you so much, sir.
Good night. Bye bye. Bye.
Thank
Thank
you.
you.
जाएगा. Thank you.